Abdomen, Chapter 10, Part 3. Renal Function Test. Alterations in renal function produce a spectrum of disorders leading to severe impairment of some organ functions, whereas others remain entirely unaffected. Sonographers should have a basic understanding of normal and abnormal values to correlate the clinical history and presenting symptoms with the sonographic representation of anatomy, disease, or pathology. Table 10.5 presents several serum and urine laboratory tests related to renal function. Urea, nitrogen, creatinine, and uric acid are used to evaluate renal function. Laboratory examination of urine specimens can detect the presence of red blood cells, white blood cells, and bacteria, which could indicate infection or tumor. Because normal values vary with sex, age, and geographic region, they are not presented in the table. Sonographic scanning technique. Patient preparation. No patient preparation is required for sonographic examination of the kidneys, but fasting augments visualization. If surrounding structures are of interest, such as the adrenal glands or the pancreas, it is recommended that the patient fast approximately 6 to 8 hours before the examination. If the examination's purpose includes assessment of associated ureteral and vessel pathology, the patient should drink 20 to 24 ounces of liquid 30 to 45 minutes before the examination to ensure better visualization of the vessels and a urine-filled bladder. Patient positions and scanning techniques. The native kidneys can usually be assessed with the patient in a supine posterior oblique or lateral decubitus position, and images can be obtained from anterior, lateral, or posterior approaches. It is often advantageous to scan in more than one patient position and from more than one anatomic site. Regardless of the approach selected, the kidney should be thoroughly imaged in at least 2 orthogonal planes. The number of images made will vary. The minimum routine examination should include 1 longitudinal sections for the renal length and to evaluate the kidneys from the lateral to the medial margins, and 2 transverse sections of the superior pole, the mid-kidney imaging the renal artery and vein and making measurements in the inferior pole. Using the liver as an acoustic window, the right kidney is best imaged with the patient in either a supine left posterior oblique or left lateral decubitus position, scanning through the anterior axillary line intercostally or subcostally. The left kidney is best imaged in the right posterior oblique or right lateral decubitus position, requiring transducer placement in an intercostal space along the posterior axillary line and using the spleen as an acoustic window. The renal arteries and veins are best visualized in a transverse plane because of their perpendicular relationship to the ultrasound beam. The right renal vessels are best imagined with the transducer placed transversely over the right kidney and angled medially. To visualize the left renal vessels, the transducer should be placed in a transverse orientation in the middle of the abdomen, just inferior to the origination of the SMA. To approximately evaluate vasculature, interrogation with pulse wave Doppler and color Doppler should be performed. For patients who can be scanned only in a prone position, a pillow or rolled sheet placed under the abdomen at the kidney level compresses anterior soft tissue and stretches the posterior muscles. This reduces scattering and absorption of the sound beam and enlarges the acoustic window between the iliac crest and the ribs. Images of the bladder and distal ureter should be obtained as part of a complete renal protocol. Post-void images of the kidneys should be included within the examination protocol whenever any degree of hydronephrosis is encountered or when scanning a transplanted kidney. More information about the lower urinary tract is discussed in Chapter 11. Measurements. Accurate bilateral kidney length, width, and thickness measurements are normally obtained in the routine procedure. Renal measurements depend on a number of variables, including age, sex, body habitus, hydration, and the individual making the measurements. Compensatory renal hypertrophy occurs following removal of one kidney because of disease, injury, or transplantation. The best correlation of renal length is body height. The adult cortex is generally more than 1 centimeter in thickness over the pyramids. However, measurement of cortical thickness demonstrates greater inter-observer and intra-observer variability as compared to other measurements of renal size. Doppler examination. For a discussion on Doppler evaluation of the hilar vessels, see Chapter 4. Doppler examination requires education and experience to obtain useful information to contribute to the renal examination. The patient must be able to cooperate with instructions, remain immobile, and suspend respiration when required. With some pathologic conditions, it may be difficult to obtain this level of cooperation. The patient can be positioned in either the posterior oblique or decubitus position for either the pulsed or color Doppler examination. The segmental, interlobular, and arcuate vessels can be examined from a lateral intercostal approach. Transducer selection requires an adequate frequency and focal zone depth to penetrate and interrogate the renal artery. The Doppler sample volume should be kept small, 2 to 5 millimeters. All velocity measurements should be made with a Doppler angle of less than 60 degrees between the direction of flow and the Doppler beam. There may be instances in which a Doppler angle of less than 60 degrees will not be obtainable despite the sonographer's best efforts. This will lead to falsely elevated velocities, which should be viewed with suspicion. To offset problems related to inaccurate resistance measurements, the wall filter should be set as low as possible, less than 50 Hz, so that important low velocity information is not hidden. To minimize relative error and to maximize the Doppler tracings, use the smallest possible frequency range, pulse repetition frequency. Pulse Doppler provides valuable physiologic information regarding intrarenal vascular flow, and spectral analysis is helpful in assessing peripheral arterial resistance, hydronephrosis, and other diffuse renal diseases. Color Doppler is useful for evaluating renal artery occlusion and stenosis, aneurysm, pseudoaneurysm, arterial venous fistula, AV malformation, and venous thrombus. Power Doppler provides additional anatomic information by demonstrating the entire renovascular tree. The major advantage of Power Doppler is that normal blood flow is demonstrated better, including renal cortical blood flow. Power Doppler is especially advantageous to evaluate renal perfusion in cases of flank pain or trauma, congenital and acquired renal vascular lesions, and hemorrhagic or tumor thrombus of the renal vein. To evaluate vascular and parenchymal disease, the segmental, interlobular, and arcuate intrarenal vessels are routinely examined. The Doppler sample volume is placed inside the renal hilum for the segmental arteries along the border of the medullary pyramids for interlobular arteries, and at the cortico-medullary junction for the arcuate arteries. The sonographer should obtain and analyze several consecutive identical waveforms and examine both kidneys. The resistive index, or RI, is calculated to characterize intrarenal impedance. The RI is an index of pulsatility over a cardiac cycle determined by the following formula. RI equals peak systolic shift minus minimum diastolic shift divided by peak systolic shift. The normal pulse Doppler examination will show a low impedance waveform with decreasing peak systolic velocities as the vessels are traced distally. The RI reported for the normal adult kidney ranges from 0.58 to 0.64 plus or minus 0.05. An RA of 0.70 is generally considered the upper limit of normal for the adult kidney. An RI value of greater than 0.70 shows excellent sensitivity and specificity in distinguishing renal obstruction from unobscured dilation. In cases of physiologic extremes of decreased heart rate and hypotension, the RI can be evaluated even in the absence of renal pathology or a true change in renal vascular impedance. Correlating the RI with heart rate and blood pressure is important. When main renal veins or intrarenal parenchymal veins are examined, Doppler signals show continuous flow in the direction opposite arterial flow and variation due to both respiratory and cardiac activities. Technical considerations. For better kidney visualization, deep inspiration helps push the liver, spleen, and kidneys down below the ribs as much as 2.5 centimeters. Visualizing some portions of the liver with the right kidney and the spleen with the left kidney is important, as their echo amplitude should always be compared to that of the renal parenchyma. Pitfalls. Although the kidneys are relatively easy to identify sonographically, there are pitfalls. The normal kidney is an anisotropic organ, which means that its appearance varies based on the angle of the ultrasound beam. On transverse section, the kidney often appears more echogenic than on corresponding longitudinal images. This is due to the relative difference in the number of acoustic impedance mismatch interfaces encountered. Respiratory motion or failure to visualize the true long axis of the kidney can lead to underestimation or overestimation of renal size. Athletic patients and young men frequently have prominent hypertrophic sized muscles that can simulate a renal or adrenal tumor and should not be mistaken for retroperitoneal fibrosis. A technique helpful in differentiating muscle from mass is to instruct the patient, when they're lying in a supine position, to flex or pull up the legs while observing muscle contraction with real-time sonography. Other anatomic structures, adrenal glands, liver, spleen, pancreatic head, and pancreatic tail, lie close to the kidney's upper pole and can simulate masses arising from this region. Congenital or developmental anomalies can make kidneys appear diseased or difficult to identify. Atrophic kidneys pose a significant challenge as they are quite small and difficult to outline. Large or multiple cysts can be mistaken for hydronephrosis, and pseudohydronephrosis can appear secondary to overfilling of the bladder or rapid hydration. An ectopic or transplanted kidney can be confused with a pelvic mass. Rib artifacts, especially at the upper poles of the kidneys, can cause shadowing and obscure pathologic processes. Duplication artifacts due to refraction of the sound beam can occur at liver, fat or spleen, fat interfaces, which can mimic an area of cortical thickening or a mass. The artifact occurs more commonly in the left kidney and occurs more frequently in obese patients. Changing the transducer position to entirely interpose the liver or spleen as an acoustic window in scanning renal tissue helps eliminate this artifact.